Very good. Well, good evening and welcome to the 7th summer of this Healthy Living lecture series brought to you by UAF Summer Sessions and Lifelong Learning. I'm Mike Powers. I'll be introducing tonight's speaker. As a reminder, these lectures, as well as the lectures on Monday night, Discover Alaska, Healthy Living Tuesday, Wednesdays is another series. Tomorrow will be the legendary Stan Justice talking about trails, are really brought to you as a longtime effort of the university connecting with the community, and most recently, Michelle Bartlett's efforts in making these courses and lectures and travel programs come to life. So with that, let me introduce tonight's speaker, Dr. Peter Dillon. Dr. Dillon's a key medical leader in the Tanana Valley Clinic First Care Team, board certified in family medicine, member of the American Academy of Family Medicine, Uniformed Services Academy of Family Physicians, American Society of Addiction Medicine, American College of Sports Medicine, and the Wilderness Medical Society. Specializes in family medicine, but also interested in addiction medicine, wilderness medicine, pre-hospital medicine, and combat and tactical medicine. Dr. Dillon came to TVC from the United States Army, serving at Fort Wainwright, continues to serve as Lieutenant Colonel in the Army Reserves. He's developed multiple times, or deployed multiple times, supporting special operations and conventional combat and contingency missions around the world. BA with the Ohio State University, graduated summa cum laude, graduated med school from Georgetown University, completed his residency in family medicine at DeWitt Army Community Hospital, Fort Belvoir, Virginia, including service through the National Capital Consortium, Walter Reed Army Medical Center, and the Uniformed Services University of Health Sciences. Outside interests, largely focused on family, 3 little boys, fishing, hiking, exploring Alaska, headed to Valdez next week. Tonight, Dr. Dillon will be presenting a medical perspective related to methamphetamines. And please join me welcoming Dr. Pete Dillon.
Appreciate that. Thank you. So I'm really excited to give a talk in person this year. I spoke last year virtually, and that has its benefits. It's maybe a little less anxiety provoking for me, but has its drawbacks. I still have not figured out a year and a half into virtual meetings how to take questions during a lecture from a Zoom meeting. So if we're all okay, even if it's on the first slide, just jot your question down, send it to the chat box, we'll get to it. But I've managed to mess up many a Zoom meeting by trying to answer questions in real time. So based on my technical challenges, and I promise we have a great IT and AV team here who are going to help me out. But if it plugs into a wall or if it relies on the internet, I'm the guy who's going to break it. So thank you for that introduction. And certainly a big chunk of what I do for a living now revolves around treatment of substance use disorders. I spoke last year about opiate use disorder, which certainly over the last decade has gained quite a bit of traction in the lay press, but a very, very problematic substance that plagues the United States, but also the world at large. Stimulant use disorder, specifically, we're going to talk tonight about methamphetamines. So not my favorite subject to talk about because I don't have a lot to do at this point as far as what we can talk about, and we'll get into the science of why that is. And hopefully we'll generate some good dialogue and maybe answer some questions and provide some insight. And I hope my passion for this type of medicine comes out in the talk. If nothing else, we take that away. We have really gifted clinicians in our community who work very hard to address this, in some cases, overwhelming and certainly very devastating problem that impacts depending on which study you look at, but even if you're not comfortable raising a hand, but probably in your personal reflection, somewhere in your lives, you've been touched by addiction in one way, shape, or form, maybe not personally, but most people can say they know somebody or there's a family that they know who's struggled with this in some way, shape, or form. And certainly one of my big reasons that I enjoy this medicine is the personal change in perspective it's afforded me. Addiction doesn't care who you are, what color you are, how old or young you are, how much money your parents have. what side of the tracks you grew up on. These are all the things that I thought about addiction before I entered into the world of treating folks who suffer from it. And then the concept that this is a disease and it's a lifelong disease, and we're going to talk about what that looks like. So I will go ahead and get started, but please jot your questions down because I am not an expert in any of these things. Every day I am learning from my patients with every time we have a conversation. So here's our objectives. As you heard, my training and background is very heavily influenced by the military, so you can't get up and talk about anything without stating why you're going to talk about it and what you're going to accomplish in the time you've been allotted. So here's our objectives. I have no conflicts or disclosures. Addiction medicine is not a specialty one should choose if they're interested in becoming very wealthy. So what we'll talk about is stimulant use disorder. And so I've provided here a couple of statistics looking at it. Now, the majority of literature studying stimulants specifically is focused on cocaine. And the reason for that is it is, and historically was, the most widely used and available stimulant that found its way into the United States, specifically in both a powder form of cocaine produced mainly in South and Latin America, but then crack cocaine and the devastation that had across mostly the inner cities of the United States. So the majority of literature that's out there is still focused on cocaine, and that serves as the model generally for stimulant use disorder and some of the framework for the treatments that have been developed. Methamphetamine works in a very similar pathway, but it is incredibly destructive, both on the cellular level, the personal level, the person sitting in front of you, and then its devastation at a community level. So we'll talk a little bit about that. So meth got a lot of notoriety in the United States. Initially, it was the cook labs, right? You hear about these stories, people are making meth in their bathtub and then it explodes. That still happens. There's a reason when you go to Fred Meyer right now to get Sudafed, you have to show your driver's license, and the state of Alaska caps how much Sudafed that you can use. Depending on the season, occasionally when our birch pollen counts hit those world records that we've experienced in the last couple of years, the running joke that comes through my clinic is pollen counts are so bad they're taking the meth and making Sudafed out of it again. But it is really easy to take Sudafed and manufacture methamphetamine. Most of the chemicals it's required you can buy at Home Depot. That said, that is not the methamphetamine that the majority of folks suffer from using and experiencing now. There are these mega production labs. Most of them are housed in Mexico, and these are producing hundreds of kilograms of methamphetamine, and then that's shipped and distributed through the United States. So that still is a big problem as far as that the smuggling, the illicit trade that surrounds all controlled and illicit substances and all of the things that go with it. So weapons trafficking, human trafficking, drug trafficking, the underlying process is violence, and it never ends well. And the people who perpetrate those crimes they're business people, and they're very good because the things they sell, people are willing to pay a lot of money for. So again, there's other stimulants that are found in the other parts of the world. Some of these are culturally acceptable. Sub-Saharan Africa has a plant-based amphetamine stimulant called khat that people will use. Some of my experiences with the military were through that part of Africa, and you'd see folks who chew this more similar to what folks in the United States will use as chewing tobacco. They're very similar to that, and it's culturally accepted and part of what they do. Again, still does come with some of the same impacts that we're going to talk about, at least how it works in your brain. So one thing I will touch on, we'll have some slides to demonstrate this. People who sell drugs are not necessarily the most honest folks on the planet. It might come as a surprise that if you think you're buying heroin or ecstasy or cocaine or methamphetamine, that's not all you're getting. And certainly we keep close tabs on sort of trends throughout our community, what people are using, what they report they use versus what their substances that we identify through urine toxicology screening. And so there's not really good meth, if that makes sense. There's bad meth and good meth and bad meth. But what that translates into is dangerous meth. And the majority of the methamphetamine now that is distributed in the state of Alaska does contain fentanyl in it. And the difficulty with that is the overdose death rate goes up significantly whenever fentanyl is introduced into any substance. So I've given a couple of slides here about what substance use looks like across the state, but this is an incredibly expensive problem. It's expensive in social services, it's expensive in healthcare, which is part of what I interface with. It's very destructive, and it costs a lot, whether it's lost productivity, and I'm a picture, shapes and colors is sort of my baseline. But if we look at this, the healthcare impact is measured in billions with a B. Criminal justice system, again, it's an incredibly expensive problem, and it's not going away. And despite what we do in the treatment realm, the programs that we enter with our community-based efforts, we probably can't spend enough money to fix this problem is what I have come to the conclusion. There's not a lot of evidence that looks at that from a epidemiology standpoint, but there's not enough folks. And one of the things I've come to the realization is that if I so choose, I could probably work in addiction until I breathe my last breath, that I may very well listen to somebody's story and then keel over dead in the exam room. So this is a big problem and not going away anytime soon. So this is specifically to Alaska and looks at the overall use. And the punchline from this is, again, as we talked about how many people in this room or online or watching have been impacted by this, the reason for that is a lot of people use drugs. It's not something that it's an insignificant or rare event for people to use that. And these are things that people use because they're not happy. They don't feel good and they take different substances, alcohol, tobacco, prescription medications. Those tend to be the first pass that a number of people will go down that pathway. They take a pill at a party, they sift through somebody's medicine cabinet at home. For those of you who've heard me lecture before, throw away, dispose of your prescription pain meds. You don't need a bottle of Vicodin hanging out in your medicine cabinet, because I promise you are not going to be the only person who takes that. The majority of my patients do, in fact, have their first experience with opiates through somebody's medicine cabinet. So this is one of the more important slides in the slide deck. And if you look at this, this is really impressive in that the tremendous impact this has in our native population. And so the almost fourfold increase in methamphetamine related overdose death. Now I'll talk a little bit about how methamphetamine kills people, but the majority of this specific slide and the trend can most likely be attributed to the rise of fentanyl being mixed into methamphetamine. Certainly meth will kill people. There's no such thing as a safe amount of meth. I always say that to all my patients. But this stark increase that we're seeing, and again, as you look at that, the very, very alarming trend is how that impacts native health populations. So we're going to transition a little bit. I've talked a little bit about why meth is a problem. I'm sure that's not news to most people who are paying attention to this lecture. We're going to talk a little bit about what is addiction and why is addiction so challenging to address. So this quote, I found this in a Lancet article. So I always like reading it. It's a complex disease of a complex brain. And the article goes on to further capture that by saying it's the most complex disease of the most complex structure in our known universe, right? So what we're going to talk about neurotransmitters. We're going to talk about filling a void or an emotional loss. It's really hard to talk about that objectively, right? We can talk about dopamine. There are some objective measures on that. But what we're talking about in many cases is emotional and behavioral health disease. These are really difficult things to measure objectively. And again, when it comes to addiction, it is so challenging to pinpoint this is the reason. This is why it's so hard. It is all of the things, right? Your patients have so many complicating processes. And generally, by the time they're talking to somebody like me, they have been treated terribly by other people in their families, other healthcare professionals, because so much stigma and shame surrounds both the use of substances and why did they start using the substances in the first place. So again, there's a lot of barriers to healthcare. And so again, I really like this quote because it makes it easy when I can say, I have no idea. And the reason I have no idea, because nobody has any idea how to take care of this. But this disease is chronic. Just because you're in recovery and you've been in recovery for 15 years doesn't mean that on year 15 in one day, you're still going to be in recovery. People can make tremendous strides, and that part of their brain, and again, we'll talk about why this is so powerful. It can be a trigger as simple as a hand in somebody, change in their pocket. It can be a sight they see, a smell. Again, a lot of these things, and they're very powerful stimuli that create this drive. And again, people can go from very impressive progress in recovery, leading from the outside in, very normal appearing lives without any really long-term problems associated with their drug use, and be right back into a very problematic use pattern within a day. So we'll talk about the difference between addiction and dependence. So addiction is what we in this room define, right? So I mentioned khat in sub-Saharan Africa. You're not addicted to khat. That's what you do. You wake up and you start chewing khat. It's not an addiction because that's what's normal. It's acceptable. One of the ways I compare this is alcohol use. So in alcohol use, if all of us were at a dinner, right, and someone came around and said, hey, anybody having something other than water with their meal, that's socially acceptable. I can have wine or beer or whatever with dinner, and that's socially acceptable. If we all then went to breakfast the next morning and I polished off a 12-pack, right, probably not acceptable and somewhat outside what's social norms. If I then got behind the wheel of a car with my 12th beer, now I'm breaking a law, right? So we have this legal complication that's developed. And so again, society is what defines your addiction. So again, you don't have to be addicted to a substance. You can be addicted to a behavior. Gambling is a common one that we talk about quite a bit. Now, that is very different than the physiologic dependence. So dependence is I take this substance, I have cellular changes in my brain and elsewhere in my body. And if I don't use that substance, I don't feel well in whatever capacity that means. So dependence is I need to take this to feel well or feel normal, or I need to take more of a substance to feel the effects I did, say, a month or a year ago. So again, there is a difference. They're related, but they are definitely and importantly different from one another. So what I'm going to talk about now is what's now mostly accepted as the way addiction works. Now, this is still all theoretical. We don't take people, expose them to substances, euthanize them and cut their brains open and look at them. But we do have things like functional MRI right now, which are really fascinating in the way we can see the way these substances work and the changes that occur in the brain. Now, these are the gross changes. What I mean by that is they're not under a microscope. So these are functional studies looking at the various aspects and places in our brain that get activated depending on what we're doing and what things we're engaged in. So addiction has many factors, as I talked about. Some of these are in your prefrontal cortex. And I will clarify here, I'm not a neurobiologist. My neurobiology grades would probably make everybody a little bit embarrassed in this room, but I can read them, and the pictures, again, I'm a shapes and colors guy. They're pretty impressive, and these segments of people's brains light up in a really remarkable way. What we are talking about is the reward system in our brain. Dopamine is the one we'll focus most on. This is the oldest part of our brain, what's sometimes referred to as the lizard brain, the hind brain, right? So this is the most basic component. This is the I need to survive part of my brain. So my basic survival is I need to eat, I need to survive, and I need to pass on my genetics to the next generation, right? So these are things that feel good, right? So if I eat, I feel good, right? My stomach doesn't feel bad. I'm engaged in a loving relationship and I have children. These are things that feel good, right? So these are what are normal and acceptable. But when people use substances like we're talking about, and in the early phases of substance use, this looks at we're activating that reward system, and we're talking massive spikes of dopamine, right? And this isn't the, I feel better when I eat a piece of chocolate. We're talking specifically with methamphetamine. That is probably the substance that people abuse that has the greatest dopamine release. And we'll talk a little bit, I'm not going to get into the whole histochemistry because that stuff makes me want to take a nap, but this is the most potent way that dopamine gets released. And so when you first use it, you feel awesome. Like, I want to do that again, right? And so that's the beginning of addiction, right? I have this reward and I want to continue to feel that way. And methamphetamine is very quick in the way it impacts your brain. We then get into, we start to see this withdrawal and negative effect. Well, now I need to take more, right? And now when I don't take as much as I used to, I don't feel as good. And now I'm starting to transition. I'm not using this to party on the weekends. I'm using this to be functional as we start to see these types of things change. And again, this can be very rapid in the span of weeks, specifically with methamphetamine. Again, I am taking relief because without this substance, I don't feel good. I may not necessarily feel sick, but I don't feel good. And then we get to the last part. And this is where I'm preoccupied because effectively without this dopamine releasing substance, I cannot function. I am not going to survive. That is the preoccupation. And that is what can be so devastating, right? When you take somebody who is clearly experiencing negative effects of their use and say, why can't you just stop? The number of parents that I address who say, I just don't understand why he or she can't stop using. It's because they, at their most basic part of their brain, they can't, because without this substance, they cannot have a normal dopamine response that most of us enjoy. And so this is where it starts to cause dysregulation of our normal processes within our brain. These are folks who use not to get high anymore. They use because without using, they can't get out of bed. They can't engage. And again, the only way these folks can feel normal is with the substance. And without the substance, they generally feel terrible. So this is the brain disease model. And again, with some functional MRI studies that are really powerful, present really compelling visual changes in people who use substances' brains, we are seeing the model accepted. This is no longer the Nancy Reagan in her red dress telling you don't do drugs and you're a bad person and you've made bad choices and you have a weak constitution and maybe you haven't found God or Allah yet, and that's why you use drugs, right? We're moving away from that and more towards that accepted model that this is a lifelong disease. And again, specifically to methamphetamine, it is devastating at both the cellular and the gross level of people's brains. And so with that, I talked a little bit about Nancy Reagan and the don't do drugs, but does everybody remember the cracked egg? This is your brain on drugs. So I'm a child of the 80s, right? So I went through the DARE program, which told me as soon as I even looked at a joint, I was going to be injecting heroin. And that the minute that I started down the pathway of using drugs, my life was going to be completely overtaken by all drug use. And that turns out it's actually probably not true. Again, I don't know, but because the message stuck for me for some reason, or maybe it was my very heavily disciplined. My father was in the military too. So again, there wasn't a lot of room for goofing off with me, but this actually does hold true in some ways with methamphetamine. It does when you deal with someone who's been a heavy meth user for a very long time, they'll even describe it themselves. I've cooked my brain, right? Again, it does damage that is in many cases irreversible. But different, and what's on this slide is trauma is probably much more likely the gateway and not the first time I took drugs. It's why did I take those drugs in the first place? And so certainly early childhood trauma, and I have conversations with patients every day. And I saw a clinic earlier today and again, told this individual, it's your story is yours. Your experiences are yours. They are unique to you, but the themes are probably something I've heard before. You may or may not have experienced living in an environment where you had your primary caretakers who are using drugs. So if you see someone using drugs when you're small, you're much more likely to use drugs, because those same intoxicated parents probably aren't doing all the best job at taking good care of you, right? And so some of your basic needs aren't being met. Maybe, maybe not. Many of my patients have experienced violence, whether it's physical, sexual. Most of them have experienced abuse of one variety or another. Again, physical, sexual, emotional. The list of adverse childhood events is long, but it doesn't mean that every person who's experienced those problematic events will end up developing a substance use problem. But the more of those things you experience, and the earlier you experience them, the likelihood that you will suffer from substance use disorder goes up significantly. And there are some studies that look at this, that in different addiction treatment realms, the statistics are as low as 50%, as high as 99%. I will tell you in our clinic experience, so this is the anecdotal answer, but it's universal. We've 100% of our patients have experienced some form of trauma early in their lives. So again, as we shift from this is something wrong with you and you're a bad person because you use drugs, we're moving towards this is a symptom of what happened to you. You use drugs because of something that happened to you. So that is the way we move into this trauma-informed care. So again, moving away from the model, using words that matter, right? So we don't refer to these patients as, oh, you're the tweaker in room 5 or the dope fiend down the hall. Patients know what that sounds like. They listen to you, they hear it, right? And it doesn't feel good, and it creates barriers for them to come in and get help. And so oftentimes just engaging with that person and say, hey, I bet you've been treated pretty poorly by somebody who looks like me, dressed like me in scrubs, maybe had a stethoscope around their neck. Is that something you've had happen to you? And again, a lot of them, the answer is yes. And just having that conversation and acknowledging the stigma that exists can oftentimes be a great starting point to building that bridge and that rapport to say, hey, we're gonna care about you, and we're gonna get you the help, and we're gonna address what happened to you and why are you using these substances? What are you using these for to treat? What happened and how can we help you? So again, I looked at that. I listed the percentage there of the various studies that have looked at this. Again, ours is probably 100%. So and then this other shift of harm reduction, and when I use that term, what I'm suggesting is, people often ask me, well, what's success look like? How do you treat addiction? And what is it? Is it that they've never used, they've never touched another drop of alcohol, they've never snorted another line of meth? Not necessarily. Harm reduction can be something as simple as, well, I used to inject methamphetamine every day and now I only smoke it. That's still not sobriety, right? We're not talking about somebody who has made a tremendous amount of progress. But if we look at this from well, are they sharing those dirty needles and spreading hepatitis C and HIV? So again, from a harm reduction standpoint, we've done some good. Again, we want to be achieving better results for that person necessarily than that. But again, that's the shift, that's the mentality. And the move from this is a sobriety-based program or a sobriety-based treatment plan to a progress-based treatment plan. If I stay engaged, if I use in a safer way less often, then I'm still making progress. So we're going to get into that histochemistry that I promised you I wouldn't spend a ton of time on. But again, as we look at this, one of the reasons why meth is so devastating, unlike cocaine, cocaine's short acting, on-off switch, 20 minutes, an hour tops, depending on how long you're using it. Methamphetamine can last for a whole 24-hour period. And oftentimes it's met with, during that period, once the high and potentially a psychosis that sets in, people continue to use it. And for all of the good things that it does and makes them feel, they don't sleep, so they keep using, they engage in using other substances. And again, the way this works, so it releases more dopamine on the upstream neuron, causing that to then also block the reuptake on the downstream neuron. So you flood this synapse full of dopamine. And at the same time, you're actually torching the upstream neuron. So again, when we talked about I cooked my brain is sometimes a term patients will use, they're actually right. They are creating such an oxidative stress on their neurons that those neurons actually die. And again, it can happen with that very first use. So again, it's a stimulant, amps you up, gets you going. Some patients will report that the first time they started using it, they're overweight. They go to college. I want to look good in my bikini. I started mixing meth into my coffee. I've heard that story. Lost a pile of weight on methamphetamine because you don't eat when you're on meth. It's an anorexant. Makes you feel good, and it makes you feel good really quickly, and it lasts a long time. So there will be patients who will use cocaine, let's say recreationally is a term that gets thrown around. Maybe people have heard that in a non-harmful way. And then they'll try methamphetamine for the first time and they'll never go back. It is that hole in their lives that is now filled by this wonderful substance. So it's also hallucinogenic. So again, people will see things and feel things that aren't there. And we'll talk a little bit about what that looks like. When you get intoxicated, you can become psychotic. If you talk to law enforcement officers about addressing patients who are intoxicated on methamphetamine, nobody's having a good day. These are generally very physically violent encounters with patients. And again, the person who is intoxicated is at risk for experiencing violence, but also at risk for inflicting violence. They're agitated, they get sweaty, their heart rate goes up, they're breathing quickly, their body temperature raises. Again, these are really, really unpleasant folks to look at from a standpoint of what do I do with them when they're sitting in front of me in the emergency department. Everybody knows about skin picking. Is that something that people are familiar with? So I mentioned that hallucinogenic property can make you think that there are things that aren't there. So folks will talk about having things crawl on their skin, pick at their skin. They'll get these terrible excoriations where they're just clawing at their arms and legs, and they come in and they have these horrible weeping open sores. And again, it's not pleasant to look at. So, and at the highest levels, some things that it can cause are seizures. So when we see overdose, I talked a little bit, we had that slide about how the impact it's had on native populations, but mostly we're talking about the same things that happen when people use other stimulants. So you can experience coronary vasospasm. So the end result of that is similar to what someone would experience with a heart attack. So basically you get lack of perfusion to the heart muscle, and that stops you from having a heartbeat and you die. You can have a stroke. Again, you get those same vessel spasms can happen inside the brain. The most important thing though has been this uptick in the concomitant use of fentanyl with methamphetamine. And again, definitely has been the precipitating reason for the big increase in death and overdose. All right, so dependence, remember we're going back to, I no longer get high now, right? I am dependent on this substance. And so these folks, they have incredible dysfunction in their ability to regulate their emotions. These are folks who are compulsively taking drugs, so they're not eating, they're malnourished. A big thing, anybody familiar with the term meth mouth? Anybody heard of that, know what that is? So that's a really fascinating phenomenon because it doesn't actually happen with cocaine, or at least not nearly to the extent that it does. So there's a few different theories out there. So again, this stimulant causes vessel constriction. So there's a theory that the gingival vessels, so the blood vessels that supply blood to our teeth and gums, are preferentially clamped down. Not sure how much truth there is to that. There is some truth to salivary gland dysfunction. So these people don't make saliva. And so once you have a dry mouth that doesn't have blood flowing to it, dental caries become really problematic, and long-term use of methamphetamine almost always results in tooth loss, gum loss. I mean, again, if you Google meth mouth, you come up with some pretty impressive pictures. So, and then at the long-term end, again, we start to see cognitive decline, and you're creating damage to the neurons that in many cases is not recoverable. And certainly it is months to years before people start to recover. So here is the criteria. How do I diagnose somebody as having a methamphetamine use disorder? Now, methamphetamine is an illicit substance, right? And so by definition, if you are defining addiction as what our society deems as what is someone an addict, well, the minute you take methamphetamine, because it's illegal, you're breaking a law, therefore you meet those criteria. Now, where it gets interesting is how severe is your addiction? Again, addicts love pointing fingers at each other. And again, people who suffer from substance use disorder, again, we try not to refer to them directly as addicts, but that's what they call themselves. And they love pointing out, well, I'm not as bad. Again, I haven't even crashed my car yet, right? Like I still have a job. I'm doing just fine, right? I'm like, oh, are you? So again, as you look at those consequences, that's where we start to really see. And so oftentimes when folks end up in our clinic at TVC, it's because they have had those consequences start to develop. So whether it's legal or health consequences, that's oftentimes when we're involved. So again, folks who misuse methamphetamine are really, really challenging. And again, not just in a clinical setting, but if this is somebody in your family or somebody you care about, or it's an employee in your business, they are really hard to address because they're agitated, they have mood swings, they are really compulsive in both their behavior and as well as seeking out the drugs that they are trying to use. Oftentimes this will spill into legal complications. People are stealing to support their use habits. People are engaged in what we now refer to as transactional intercourse. The good old fashioned term for that is prostitution. Again, these are folks who they're doing just about anything they can do to continue to use those substances. And then it goes back to that early childhood trauma and that undertreated, underdiagnosed behavioral health disease. So there are folks whose ADHD magically goes away, and for that very brief period, they are really productive. They are magically good at school or whatever it is, their job, whatever they're doing, and then very quickly the drug use spirals out of control. But ADHD, depression, anxiety, personality disorders, a lot of these folks are marginalized, and therefore they seek out self-treatment with these different substances. Okay, so when we talk about that severity of use, a couple of slides back, there are patient populations that are really challenging for us to deal with. So if someone injects a drug, that is going to create the fastest onset for that drug's impact physiologically. So if you're an injection drug user, no matter what you inject, but specifically for methamphetamine, it is really challenging because we're taking the highest releasing substance from a dopamine perspective, and you're administering it in the fastest route possible. So as we think about how I take drugs, if I were to ingest it orally, that has a slow onset, slower offset. Generally, folks who take methamphetamine that way do so for a very short period of time. And most people who are going to use methamphetamine for the first time will actually snort it or smoke it. And again, those will have a faster onset than ingestion. And then finally, the most rapid onset is injection. And again, one of the other problems with methamphetamine is when people decide to stop, since they have effectively hijacked their brain's reward system, they don't find anything enjoyable. They have this phenomenon that the medical term for that's anhedonia, but they don't have fun, period. And I will have patients who are like, hey, I really want to stop, but if this is what life's going to be like without it, I'm just going to keep doing it because I don't think I can exist this way, because it takes a very long time. So all that dopamine that's getting released, your body is not used to that. That's abnormal. So you not only have the synaptic loss at the direct cellular toxicity, but the cells that still survive, your body downregulates the normal way that you process dopamine, both in the receptors that receive dopamine and in the places where dopamine is released. So these folks, they'll have a flat affect and they are not having fun, doesn't matter what they're doing. So that makes them a lot harder to address in a way to say, hey, let's get you engaged. Let's do some therapy. Let's go for a walk. Why don't you we'll get you into this beautiful rehab. It's on the beach in Malibu, right? Again, they are at a physiologic disadvantage from what the rest of us enjoy. I do have a slide there. There are subsets of people whose use of not just methamphetamine, but methamphetamine has this higher affinity for this. People who use methamphetamine as it relates to intercourse with their partner or partners. And what oftentimes happens for those people is once you separate the methamphetamine, they can't engage in a meaningful sexual relationship. So they've not only taken away their ability to engage with what we would normally say is a normal, healthy experience. But even an intimate relationship, they are not capable of enjoying that. And again, because they've tied that experience so closely to this incredibly abnormal dopamine release, it is really problematic. And for some patients, that's debilitating, lifelong. They'll never recover from that. And again, they go back to, well, if this is how I'm going to live, I'm just going to keep using. So that tends to cluster more in men who have sex with men, but it doesn't discriminate. Again, one of the reasons why this disease is so fascinating is it doesn't care what your orientation is. That happens to straight folks and trans and everything else in between. So the other piece is, and this is what I deal with a lot in our clinic at TVC, is I don't just use meth. There are people who use just meth. But if I have been awake for 3 days on a meth bender, smoking meth every 2 or 3 hours, and now I want to go to sleep, well, it's a great time for me to use some heroin, because that will take away that fast, which is what my patients call meth, ice, crystal, there's different names, but the most common name is fast, and heroin's name on the street is slow. So again, you'll get into these cycles where people will use fast, and when they want to slow down, they'll use heroin. And when they want to feel better from their lack of heroin, they'll use meth. And they basically use this uppers, downers, all arounders, on-off switch that they're inducing. And again, really problematic to try and unpack that. So we'll talk about what do we do about it, methamphetamine. So that highlighted bold top line, this is why this is so challenging. I do not have a medicine for this. There's lots of medicines that have been explored, mostly under the cocaine use, but there is no treatment. Every few years, somebody will come out with their, oh, look at this, we did a study on 41 people. 2 years later, they'll do a study on 51 people and they'll say that didn't work, right? They're getting closer. There probably is something on the horizon, probably in the norepinephrine pathway of the brain. But as of today, there are no FDA-approved treatments for methamphetamine. We talk about contingency management, and the way I like to explain this, so this is the method that has the best evidence. Effectively, and I just took my kids to an arcade. We went on an East Coast vacation where this thing pumped out the tickets, right? So they put in their quarters, they play their game, tickets come out, they can buy things. Well, this has actually been proved, that same concept, to treat methamphetamine. So you show up to your methamphetamine treatment center and you provide a urinalysis that doesn't have methamphetamine, and you're given a voucher or a ticket for an item that you can either collect or cash in. And so, again, the reward system's gone for these long-standing users. You are recreating a reward system. Again, really hard, because I can't prescribe a reward system. I can't say, hey, if you give me 12 urinalysis studies that have no methamphetamine in it, you get an Xbox. Doesn't work that way, right? The FDA hasn't quite figured out how to pay for things like that. There are places that employ this. There's really great evidence to support it. And that does seem to have the most impressive evidence so far. Thinking about community interventions. So this is more on the preventive side. So if you can prevent somebody from experiencing adverse childhood events, they're going to use less drugs, right? But we're talking now generations long initiatives. This isn't something that's going to fix that patient sitting in front of you or who's acutely agitated in the emergency department. And then the last thing is the behavioral treatments. And there are focused behavioral therapies that look at the reward system. Really impressive evidence, very low risk from a side effect standpoint. And oftentimes you are starting to address those underlying, why did I start using in the first place? But we live in a community where there aren't a lot of resources to offer that. So again, great in theory, really tough to implement in practice. So some other things, motivational interviewing, maybe some folks are familiar with this. This is a, hey, what do you want your life to look like? Don't you think your life would be better without methamphetamine? Things like that, putting that motivation in their court. What does this look like for you? Really fascinating stuff that I think there's a lot of potential use for moving forward is exercise. So dopamine, anybody familiar with the runner's high? I've run a lot and a long way, and I've never experienced it myself, but I'm sure somebody somewhere has. But this idea that if we want to improve brain function, so Exercise has a lot of benefits. There's cardiovascular benefits, which again, if you're a longtime methamphetamine user, you've probably caused some harm to your cardiovascular system. Brain volume. So your white and gray matter in your brain are bigger in people who exercise versus people who don't. So I think there's some pretty fascinating ways to explore that moving forward. And I've yet to meet somebody who exercised too much from a standpoint of their overall health. It happens. It's really, really rare in some of the other behavioral health disorders. But again, I think that's a pretty fascinating way to help recalibrate. And again, back to the tickets and the new reward system. Again, we're not creating this voucher economy of if I save my tickets, I can get this, but I went for a run and I felt better. Right. And so again, there's some pretty impressive data. And I think that'll be an area that's probably explored pretty extensively, because again, without a medicine, we're still coming up with what our next best thing is. And then the final thing is mindfulness, right? So this mainly focuses on the trigger side of things. So if I always use when I am around my family, well, what are you going to do the next time you're around your family? And having that mindfulness of, I need to know what the approach is. I'm going to exhibit constructive behavior as opposed to destructive behavior. There's some pretty compelling evidence. That's not just limited to methamphetamine, but again, as you guys have heard me say here, there's not a pill for that. So on the next slide, here's the list of things that have been tried. And there are some studies that should say, hey, again, it wasn't as bad as if they kept using methamphetamine. Well, the baseline there is again, a pretty easy test to defeat if I continue to use, well, that's going to end terribly, right? So this made me use less. Again, addiction medicine does suffer from some limitations. The patients you're enrolling in these studies don't always follow back up. So again, it's really hard to study these sort of things. And again, there's some really compelling evidence. The most recent one looked at bupropion and naltrexone. Again, there's a lot of things that have been looked at. At the end of the day, none of them have at least yet been FDA approved. And one of the things we do, at least at TBC, is I kind of operate, I'm not board certified in addiction medicine. We do have one board certified addiction medicine doctor, Dr. Schneider, but we don't want to be the smartest folks in addiction, and we certainly don't want to be the stupidest, right? So we're not going to be cutting edge. And so until someone much smarter than our group comes up with a way to treat this disease, we're going to keep doing what we know how to do and what does have evidence to support. So I will close here as I give myself about 10 minutes or so for questions. This is just a kind of what we do, who we are. TBC does have an addiction medicine program. I'm pretty proud of it. We've been working really hard. We've actually been treating patients for over a decade. Right now, mainly our focus is on alcohol and opiate use disorders. We do have some folks whose primary diagnosis is methamphetamine use or some other substance use disorders. We're engaged. We see people at the hospital. We try and meet them where we are at. As I talked about in the beginning of this presentation, we do have some really talented individuals who work really hard. This is a really challenging patient population to address. We're talking about a generations long problem for our community and our state as a whole, and the country as a whole as well. And again, it is a tough group. And even within my colleagues in the medical field, some people I'll still hear, why do you even bother? What are you even doing here, right? And the answer is, well, we have to try, right? Because if it isn't this time where somebody's engaged in treatment, maybe it's the next time. And so there's this brief intervention model that seems to work. And the more times you hear about why you should engage in treatment, the more likely you are to engage in treatment. So again, we do a really great job. We take care of pediatrics patients. We did our first admission with our very talented pediatrics team. We'll take care of patients all the way down to 12. Fortunately, that hasn't happened yet, but I'm sure it's coming. And again, we do a lot of work with our women's center. So the birth of an infant is a really impressive time in a woman's life to say, hey, you really want to take good care of this baby. Why don't we get you engaged in treatment? So we engage with our women's center at FMH. And we have a really, really impressive community coordination team. And so we work really closely. We have a very talented group of folks at our methadone clinic in town. They work out of the Interior AIDS Association. Our partners at Chief Andrew Isaac, Fairbanks Native Association. Again, we're doing great things. We got a lot of work ahead of us. And again, as I talked, I will be very bald and very gray before we're even making a dent in this problem. But there are people who are working really hard to do so. So, and it's not just Fairbanks. We have contact with our partners even around the state, but also in Tok and Glenalla and other places like that. So, with that, that's how you get a hold of us. So, if anybody has concerns, questions, we have an email address that gets checked every day. That phone number, we have somebody check in Monday through Friday, and usually probably on the weekends too, depending on how busy we are. And so I'll close for questions. I don't know what the chat box looks like, or folks here in the audience. And I have references too, if anybody cares to see those sort of
drugs have been illicit, been illegal forever. The drug war has been a complete failure.
Okay.
And I think the doctors need to address that. And the violence that we see almost every day in the newspaper has to do, in fact, there's something right now going on, a trial about methamphetamines.
Sure.
And the solution, one of the solutions, I think, is to take the criminal element out of it.
Sure. And so I'm not going to be engaged in public policy, right? So but I can share my opinion since I'm here and I have the captive audience. I think we spend an awful lot of money on fighting drugs, right? So you described it as the war on drugs. Many of the folks who work in the addiction realm and believe that what we do, medication-assisted treatment and treating this as a disease and not as a moral failure, it sure would be nice if we didn't take this as a war on drug users, right? And so a way, certainly, we make it legal. People pay a lot of money for stuff that they want to engage in, and I bet if some of that taxation went towards funding what I do for a living, my job would get easier. Again, that's a wildly unpopular stance to take, but it's a compelling argument. And again, one could argue that people are going to use no matter what, right? It's not as if I'm going to walk in tomorrow and I promise there's never been a heroin addict who said, the only thing that stopped me from putting that needle in my arm was because I knew it was illegal. That's never stopped them. Again, this is a problem. And again, whether it's a criminal element, I'm sure my law enforcement friends would say that's a crazy stance to take, but there's a compelling argument to be made. Again, using these substances and then getting behind the wheel of a car, right? That should probably still be a criminal act, I think. Again, there's a lot of people who have lots of problems as a result of impaired operation of various things. And certainly my emergency department colleagues are kept very busy by people who are doing all manner of activities while under the influence of various substances. And again, I've learned an immense amount. Practicing addiction medicine in Fairbanks has made me really good at frostbite. Because what happens when you use drugs and it's 40 below zero out? Well, you fall asleep or you take a walk with no shoes, right? It's amazing. That's not something that my colleagues who practice addiction medicine in Hawaii have to worry about. But again, there are lots of problems that are caused by substance use and that don't just stop with what happens inside the brain.
Pete, thanks very much. It was very informative. I learned a lot.
Good.
I have a biochemistry question for you.
Please, maybe I can answer it.
So correct me if I'm wrong, but dopamine is like the final common pathway for almost all substance abuse substances, right?
Yeah, for the most part, it's the simplest one for me to wrap my brain around. And again, when I'm talking to a group of folks with a very solid understanding of histobiochemistry, sure, we can get into, but this impacts, it impacts your endocrine system. This impacts other pathways. We have serotonin, norepinephrine. I mean, there are so many different things that are impacted by ingesting stimulants specifically.
I guess that's what I'm wondering about is what is it about stimulants that's different from, say, opiates or alcohol? It's not the dopamine part. What other things are part of that?
Well, so So great question. Again, I'm not a neurohistochemist. What makes methamphetamine specifically so devastating is the level of dopamine that is released. Unlike heroin, unlike prescription opiates, it's a much higher volume at a much faster rate. So it does kind of boil back down towards the dopamine. And again, it's also that devastating anhedonia that comes with the downregulation of the dopamine receptors. And again, with meth specifically, it's the destruction at the synaptic level, but then the downregulation at the surviving neurons. That said, yes, heroin does the same thing or similar. Alcohol does the same thing, but it's how long do you have to use those before you experience those really devastating effects. So again, I definitely oversimplified, and there are people whose PhD thesis defenses focus specifically on, oh, but you forgot about this one neurotransmitter over here. We get a vote too. And again, there are lots of things I could probably do just a lecture only on that. Again, I'd probably fall asleep halfway through because for me, I'm a family doc, right? It's got to matter for me. And for me, it's the person sitting in front of me. And I promise very few of those patients sitting in front of me understand those synaptic pathways. So,
as you might guess, I'm kind of a proponent of regulating drugs, but
Sure.
making them available. And I'd like to ask you about, since we've legalized marijuana in the state, have you seen a big uptick in problems because of that in your practice?
So I will answer that in a way that I think makes the most sense to me. So I read the public safety report that our news miner puts together. I read it a lot. I see a lot of familiar names and I know some faces that match up to those names given who I take care of. I have never read a public safety report that started with the suspect spent the previous 3 days smoking marijuana nonstop and then committed the following. I read that all the time about methamphetamine. I read it all the time about alcohol. Again, I read it about heroin. So it depends on your definition of problem, right? THC at its core level still does cause extremely deleterious effects to people's brains, specifically developing brains. And so that said, again, I've yet to see the impact on the legal briefs like I have with these other substances. So again, I'll look at it this way. And again, not the most popular opinion to share in the addiction realm, but I have patients who are on maximum therapy for their substance use disorder. I cannot give them more medicine. I cannot give them more therapy. I cannot plug them into any more treatment than is currently available in our community or is medically safe to proceed with. And they will say, well, you know what I did? I couldn't stop thinking about using. I went down to whichever one of the shops that they frequent. I bought a brownie, and you know what? I took a nap and I was fine. Again, is that a harm reduction approach? Certainly. Is it sobriety? No. Does it matter? They're not using heroin, right? Again, so if you take the harm reduction lens, again, I'm not sure. It depends on your perspective. Again, I'm a big believer that the war on drugs, at least from my very myopic, very, very one-sided perspective, is a war on drug users. But again, not the most popular opinion.
Be a war on drug sellers.
Again, I don't disagree with you, but I'm telling you that my perspective is not a popular one amongst the addiction medicine providers.
Not really a question, just kind of a comment. Thank you very much for your presentation. I appreciate it. My name is John Yates. I'm one of the gray-haired guys that's been doing this all his life. I've been working as a frontline grunt in a treatment center for over 25 years now. And I've seen a lot of changes in the trends of what, is alcohol, marijuana, and cocaine, and then the opioid pain medications, and then some legal changes in that, and then heroin, and so on and so forth. But what I'm thinking about is trying to find a little optimism in all this. And I was looking today, I've been working at Ralph Purdue Center for 11 years now, and I've got a census on an Excel spreadsheet that started just a couple months maybe before I started working there. And, you know, the first column is just the number of that column, and I'm in the high 900s. And most of those people have successfully completed treatment. That's one thing. This whole pandemic thing was horrible for so many people. And just some of the silver lining for us, I worked from home doing everything on Zoom for 15 months. I have clients, consumers, we call them, that went through treatment that I never met face to face. And what the Zoom did is take away a lot of barriers.
Agreed.
To treatment. Childcare, transportation, there's huge things that keep people, especially women, single women with children, out of treatment. And percentage wise, I had more people successfully complete treatment during the COVID time than any other single period in that whole 11 years. And, you know, what our administrators are trying to work with the state and federal government to keep it so we can continue doing that. Medicaid made allowances so we could bill for telemedicine, and we want to be able to keep doing that and doing hybrid groups. If we can increase access to the treatment and increase capacity, I agree with you. It's miserable. I don't take these people home with me, but you can't help but be affected by it. And at the same time, if we keep figuring out new ways, the only person I'm concerned with is the one sitting right in front of me, like you said, But if we can help that one, we help their family. I've had people come back to me and say, this is my new baby and stuff like that.
Sure.
It's amazing, but there's hope for this. There's hope for this, and I just wanted to put that out there because it's not all gloom and doom. And no, you're not going to make your first million or your second million or anything off of this. Nobody's in this business by accident either. So yeah, just thanks for letting me say that.
Hey, so I have a question, more like nuts and bolts. So let's just say, I'm a white guy. I roll into there and say, I am a meth addict. What happens next in Fairbanks?
Are you suggesting they come to my office?
Yeah.
So we say this is so brave. We're so proud of you for being here today. Let's get you plugged into the help that we can. And so that oftentimes is going to involve, and again, I'm very biased in what I'm about to say. I think we do a great job because we have access to primary care physicians. We get people plugged in. We're breaking down those barriers that we just talked about, right? So we're getting lab work. We're identifying patients who have been injection drug users and have hepatitis C. We're getting them plugged in for that treatment. We're getting them engaged with behavioral health support. We're treating their comorbid psychiatric illnesses. Again, we're doing what we know how to do. Do I have a voucher-based contingency management program that's funded by a grant through the federal government? No. Can I talk to them about, a way when you're feeling gloom and doom and you can't seem to have any fun with anything is, why don't you start your day every day with some mindfulness meditation? Why don't you go for a run? Again, why don't you come in here once a week and we're a safe place for you to talk to us and in a way that you can engage where you're not going to be talked to as if you're the tweaker in room 5 or the guy with meth mouth down the hall, right? Again, just having that dialogue can be really useful. And again, plugging those patients into those other healthcare services, because the patients who are using meth every day, they're not getting their colonoscopies scheduled. They're not taking their blood pressure medications, right? They are not meeting those other healthcare metrics, and oftentimes just engaging, treating that person as a person and not as an addict, as a patient, again, consumer, whatever term you want to use to describe them. That's really useful. Again, the amount of success that we enjoy when you address the comorbid psychiatric illness is really impressive. And so we have lots of patients when they are engaged in good behavioral health care, taking their medications appropriately, they don't use that much methamphetamine, maybe very rarely, or maybe not at all. and another way is if they are just a strict methamphetamine user, we plug them in with Narcotics Anonymous, a 12-step model. We plug them in with other things that are available. Again, Zoom, again, I can say it is useful. There's barriers to it, right? You got to have a phone that works. You got to have an internet connection that works, right? It's not for everybody. You do have to own a screen or have access to a screen. Not everybody does. But we plug people in with that way. And then I'll be totally honest with you. I don't meet a lot of strict methamphetamine users. I meet a lot of people who use a lot of drugs, right? So maybe I use meth and I use alcohol. Maybe I use meth and I use heroin. I can treat their alcohol use disorder with a medication. Again, I can do all those other things I just described, but oftentimes we're breaking a cycle. And for the patient who uses the meth heroin on-off switch that I described, we can treat their heroin use, right? So we can treat their opiate use disorder with really good medications. And it's amazing when they stop buying heroin, it's weird. They stop buying meth because the guy who used to sell them heroin, guess what he sold them, right? Again, so breaking that cycle is really useful as well. And again, I don't meet a ton of people. Again, it is a less than 5% in our program who are a single substance user. Polysubstance use is the standard. That is the baseline. That is where most people exist, at least in our clinic.
And so they can see a behavioral health person like a social worker, or?
So we have a licensed clinical treatment. We have Dr. Jamie Sawchuk is part of our program. We engage with Ralph Purdue Center. And again, I put up that slide about our community approach to this. Depending on where they're at in the community, where they're at with their ability to engage with healthcare. Again, there are Zoom options for them to engage with behavioral health treatment, counseling online, a number of different things that we can plug them into.
Do they have to have insurance?
So that is a great question that I don't have the best answer to. I will tell you this. We are really good at making sure that our patients have access to Medicaid. And so they may not show up with insurance, but before too long, we were able to usually, not universally successful, but patients who come to TVC do have to have a way to pay for it. But it's not just the access to the clinic. If we're going to treat them with a medication, specifically, let's say we're going to treat them for alcohol use disorder or opiate use disorder, those medications are hundreds of dollars a month. And you know, it's not hundreds of dollars a month, heroin, right? So again, if I would like to get treatment, I can either pay out of pocket to not get high, or I can, for way cheaper, go get high and keep doing what I'm doing. So again, it's not just the office visit, and there's more to it. There's also some other pieces to that is stages of recovery include what a lot of my patients now refer to as adulting, right? Like showing up to my appointment, being able to complete the paperwork to process Medicaid benefits or some other insurance benefits, holding a job, right? These are markers that we can use objectively to say, my goodness, look at the strides you've made in your recovery, right? You were somebody who was on your last rope, living in wherever you could find a bed, paying for your drugs with any crime you could commit. And now you have a job, your kids are back in your custody from the state, and you're in school with a plan to continue on your professional career, right? Again, it can be really rewarding for those patients. And again, it's very gratifying when you have those encounters.
But they won't like get stopped at the front desk when they go in there and say, like, if you want to join this program, we need $325.
Yeah, so that is a phenomenon that plagues addiction treatment in general, and it really makes me uneasy. So if somebody's willing to tell you that they can cure your meth, you just got to sign here and swipe your credit card. Usually they're not doing it for the right reasons. I also, again, I'm going to come across as a very biased person here. If you are willing to participate in our church, but we'll cure that meth right out of you, again, that makes me really uneasy. And again, I'm not suggesting that there aren't faith-based programs that are wildly successful. It's just not what we do. Ours is not that there is no coercion in what we're doing. We aren't a true exchange of, if you do this, we do this. We'll take anybody. So.
First of all, thank you. Fascinating presentation.
Thanks.
What words of wisdom would you perhaps share with family members or friends who are of the belief or being told that the person's not going to quit their mind up to quit, so don't bother?
So I do hear that sentiment. And certainly there's an element that you can't force somebody into treatment, right? They do have to engage on some level. The approach we take with our clinic is we don't ever kick anybody out, right? You can use meth all day long. At some point, you may need a higher level of treatment than what I can provide, right? And all that means is I'm not done taking care of you, but I'm going to ask this other place where instead of coming to see me once a week, you go live there and you live there for 6 weeks or 6 months or 2 years or whatever it looks like. And so again, if this is a family member or a friend, you don't have that luxury of the treatment relationship. Again, you don't get to choose your parents. You don't get to choose your family, right? You just support them, right? And you continue to address them in as non-judgmental. And it's incredibly frustrating. And this probably what I think about when and again, I don't have a ton of personal experience with this at a family level, but I talk to enough people to see this. One of the most frustrating things for a lot of family members, and this is reflected in the disease process. One of the ways I explain this to patients and families is addiction is a disease of dishonesty. And what I mean by that is not that the person who uses drugs is a liar. That's not what I mean. They lie, right? They do that. That's a learned behavior. That's one of the most destructive learned behaviors when it comes to family and other relationships. But the disease tricks the way their brain thinks, right? I'm just using on the weekends. I can stop whenever I want. I'm only partying with my friends. Well, okay, great. And then that self lie that you're telling yourself then spills over into your family, your spouse. Where were you last night? I was just out. No, you were high, or you were stealing to go get more money to go get more drugs. You start lying to your employer. Why were you late? Oh, I had a flat tire. No, you were hungover, right? Again, and then as this starts to snowball, it then becomes untenable for those folks. And people don't like being lied to, right? Nobody here in this room does. And again, if that's your family member, that is one of the ways, in my opinion, that this is so destructive. And again, you talk to these patients about it, and it creates this shame. My family won't even talk to me anymore. I'm a failure. I'm a disappointment. I always was. Again, there are terrible examples of this kind of pattern of behavior. So my advice is always, again, understand this is a disease, right? This isn't a decision. Sure, are there decisions that are made? Yes. But again, if we go back to that brain disease model, when you reach that stage of use, you are not using because you're making conscious decisions. You are using because the most ancient part of your brain is telling you, even without a conscious acknowledgement, that you have to use. So again, that's my advice. It's not easy. I say it a lot. How many people tell me that it actually sunk in with them or their loved one? I don't know. It depends. Sometimes more than others. But it's hard. It's hard to support somebody through addiction, for sure.
So that brings us to 8:15, and I would like to thank Dr. Pete Dillon for a great talk. Please give him a hand.
Thanks, everybody. Hopefully you learned something.